Dr. Maha Youssef, lecturer of endocrinology and internal medicine, Cairo University. She will speak about diabetes and the kidney. She's one of our rising stars, as always.
Thank you very much. Thank you very much. I'm very honored to be with you today in this virtual meeting discussing diabetes and the kidney. We're going to start off with a very brief introduction. It is known that kidney is a vulnerable organ as well as the most important target of microvascular disease in both type 1 and type 2 diabetic patients. It has become the single most frequent cause of end-stage renal disease in both developed and developing countries. It is not an understatement when we say that it's a medical catastrophe of worldwide dimensions. In 2017, the IDF predicted that there were 451 million people with diabetes worldwide. The number was expected to increase to 693 million by 2045. 90% of these patients have type 2 diabetes. Nearly half of type 2 diabetic patients eventually progress to chronic kidney disease. You can imagine the magnitude of the problem. To be honest, the molecular biology behind the pathogenesis of diabetic kidney disease is very, very complex. This is a very simplified algorithm discussing how hyperglycemia eventually leads to diabetic kidney disease through renal hemodynamic changes, activation of the RAS system, ischemia and inflammation, increased oxidative stress via increase in a multitude of substances. The end result is efferent arteriolar constriction and glomerular hypertension, podocyte injury, proteinuria, tubulointerstitial fibrosis, tubular atrophy, mesangial cell expansion, and so forth, leading to the problem of diabetic kidney disease. Please kindly remember this slide when we discuss the new innovative therapy that is suggested for the management of diabetic kidney disorders. First of all, we have to start off with screening. Up to this moment, microalbuminuria is the earliest detectable marker of diabetic kidney disease, and hence the ADA recommends annual screening of urinary albumin-creat ratio and estimated GFR in patients who have had type 1 diabetes for at least 5 years, and in patients with type 2 beginning at the time of diagnosis, and in all patients who have comorbid hypertension. What are the challenges and the opportunities in developing new therapies for diabetic kidney disease? First of all, we start off with the conventional therapy, which includes, of course, better hyperglycemic control, RAS blockade, other management such as lipid-lowering therapy, and so on. And until this moment, RAS inhibition has proven to be the single most effective therapy for slowing the progression of diabetic nephropathy. However, the continued increase in diabetic end-stage renal disease means that we urgently require additional innovative therapy. And here we come to the newly approved drugs for diabetic kidney treatment. Without doubt, there's been a lot of talk about the sodium glucose cotransporter 2 inhibitors in the past years, and they have remarkably been shown to lower body weight, blood pressure, serum uric acid, glomerular hyperfiltration through increase in urinary excretion of glucose, sodium, osmotic diuresis, and improved tubuloglomerular feedback mechanism. Many studies have been done on this group of drugs. In the Cherney studies, they found that short-term treatment with empagliflozin attenuated renal hyperfiltration in subjects with type 1 diabetes. In patients with type 2 diabetes and high cardiovascular risk, empagliflozin was associated with slower progression of kidney disease and much lower rates of clinically relevant renal events than placebo when added to standard care. Canagliflozin in the Credence study was shown to significantly lower the risk of kidney failure at a median follow-up of around 2.5 years in patients with type 2 diabetes and kidney disease. In the Decker's research, the dapagliflozin showed a decreased albuminuria by around 43.9% and estimated GFR compared to placebo. Based on these studies, the sodium glucose cotransporter inhibitors have been approved to treat diabetic kidney disease patients with estimated GFR more than 45 milliliters per minute, and it should be thus included as part of the standard therapy for patients with diabetic kidney disease. What about the promising drugs in phase 3 clinical trials for diabetic kidney treatments? We have the GLP-1 agonists. According to the liraglutide effect and action in diabetes evaluation of cardiovascular outcomes result double-blind trial. This trial included around 9,000 patients with type 2 diabetes and high cardiovascular risk. They were treated with liraglutide, and the drug was found to lower the rate of new onset of persistent macroalbuminuria and the progression of diabetic kidney disease. Another randomized study of around 3,000 patients with type 2 diabetes using semaglutide had lower rates of new or deteriorating nephropathy. A recent post hoc analysis was published in The Lancet last month. It was involving around 8,400 patients with type 2 diabetes enrolled in the SUSTAIN 1-5 and the SUSTAIN 7 randomized control trials and the SUSTAIN 6 cardiovascular outcome trial to assess the effect of once weekly subcutaneous semaglutide on the estimated GFR and urinary albumin creat. There was initial reduction in the estimated GFR occurred, which plateaued, but there was marked reduction in the urinary albumin creat with no evident increase in the risk of kidney adverse events. To be noted, there was a side effect of increased risk of diabetic retinopathy, progression of diabetic retinopathy, which has to be addressed in the future studies. Based on the analysis of the clinical trials up to March 2020, and some of these trials are still ongoing till this moment, a group of leading experts in diabetes, heart failure, kidney disease, and cardiometabolic disease believe that sodium glucose cotransporter 2 inhibitors and GLP-1 receptor agonists should be considered for people with chronic kidney disease and type 2 diabetes to protect against heart and kidney disease and their serious complications. Moving on to another family of drugs, we have the Dp4 inhibitors such as linagliptin and saxagliptin. They reduce the amount of albuminuria. Up till now, the evidence is less clear than with GLP-1 analogs. We have the peroxisome proliferator activator receptor gamma agonists. Rosiglitazone again showed a significant decrease in microalbuminuria in type 2 diabetic patients after 3 months of therapy. In the Agarwal's research, pioglitazone showed a reduction of 7.2% in proteinuria, but it was not statistically significant. Endothelin 1 receptor antagonists work on blocking the effect of endothelin 1 peptide, which is a very potent vasoconstrictor, renal vasoconstrictor, and pro-inflammatory substance. The avuxintan can reduce the urinary albumin excretion, but trials involving this drug were prematurely halted due to increased cardiovascular events. A recent study in around 200 patients showed that atrasentan, a more selective endothelin receptor antagonist, had a more prominent proteinuria-lowering effect without significant accumulation of body fluids. However, future studies are required to assess its safety. We come to the mineralocorticoid receptor antagonists, which exert an anti-fibrotic and anti-inflammatory effect. We have more than one newer generations of drugs with a relatively lower risk of hyperkalemia compared to the first and second generation mineralocorticoid receptor antagonists. The isoxazolinone is being studied in phase 2 and 3 randomized clinical trials, and the finerenone has been investigated in several phase 2 randomized control trials. In the heart failure tolerability study, finerenone reduced albuminuria in patients with chronic kidney disease and heart failure and had a lower risk of hyperkalemia than spironolactone. We have 2 ongoing phase 3 trials. The Fidelio and the Figaro are ongoing currently to examine the effects of finerenone on diabetic kidney disease and cardiovascular outcomes. What about anti-fibrotic therapy? They have shown modest results, to be honest. The pirfenidone and the patoxyphilin, they have showed modest increase of estimated GFR after a year of therapy in a small number of diabetic kidney disease patients. 2 more clinical trials are still ongoing to assess these substances. What about the potential drugs which require further validation in the future? Let's talk about the hyperglycemia-associated generation of advanced glycation end products, and the engagement of the receptor of advanced glycation end products with its ligands can induce oxidative stress and renal inflammation. It was found that pyridoxamine, a member of the family of vitamin B6, can remove free radicals and carbonyl products and block the synthesis of advanced glycation end products. The JAK2 inhibitors, it was found that the JAK signal transducer and activation of transcription pathway are heavily involved in the pathogenesis of diabetic kidney disease. This pathway is activated by reactive oxygen species induced by the hyperglycemic state. Phase 2 clinical trials using baricitinib, a selective JAK1 and JAK2 inhibitor, showed a reduction of proteinuria and expression of several inflammatory markers. It shows very promising results up till now. We have the nuclear factor 2 erythroid-related factor pathway. More pharmacological activation of this pathway decreases cytokine production, macrophage accumulation, and the formation of an atherosclerotic plaque lipid core in experimental models. In addition, its activation improves the pathological changes in the glomerulus of diabetic mice. We are still in the very early experimental phase. Bardoxolone methyl reduces the generation of oxidative stress by this pathway. However, the large phase 3 clinical study was terminated early because of more cardiovascular events. We have the NADP-H oxidase enzyme isoforms involved in the production of reactive oxygen species that cause kidney cell injury in diabetic kidney disease. The results of trials on experimental models are still questionable regarding the NOX1/4 inhibitor and the pan-NOX inhibitor and their renal protective effects. This is just a summary of what we just mentioned, the newly approved drugs, including sodium glucose cotransporter inhibitors, and the promising drugs in phase 3 clinical trials, whether the GLP-1 agonists, endothelin-1 receptor antagonists, and the mineralocorticoid receptor antagonists. What are our take-home messages? When we identify high-risk patients and ensure targeted therapy as appropriate, we could greatly reduce the burden of heart and kidney disease for millions of people with type 2 diabetes. Hyperglycemia should be managed with a multifactorial approach, including weight loss, exercise, diet modification, and medications. Lifestyle changes and metformin remain the first-line therapy for patients with diabetes. Secondary data analysis of intermediate renal outcomes in large trials suggests that medications from multiple drug classes may help to reduce progression to diabetic kidney disease independent of their glucose-lowering mechanisms. We need more trials. We need to test the cardiovascular and safety and otherwise of these potential medications for diabetic kidney disease. We need to curb the rise of end-stage renal disease due to diabetic nephropathy. Thank you very much.